Okay, I believe we are finally, okay, got it? Okay. Representative Al? Okay. Thank you to all of the members who helped us get a quorum. I appreciate it. I hope more people will come. I know that we're meeting on top of each other, so I will officially call the meeting of the Public Health, this meeting of the Public Health and Committee to order, and so that we can, before we lose a quorum, I'm going to take up Senate Bill 162 LC 339815S, Mr. Senator Huffstetler's bill, and if you will look at it, it also it includes the bill that we passed at the other day for the Board of Medicine to regulate these clinics that are popping up all over our state and using ketamine offline and as other drugs that are or do they call them psychedelic drugs, or what, that are being okayed and soon will be props available to people to use by a doctor that is not using them offline. But if those are coming on board, they'll be set up so that we don't have the same problem we had with pain clinics when they got started all over this state, and they were not really helping people for pain, they were helping them become addicted, and we had to go in and change that. So with that, Senator Huffstetler, you are recognized to talk about your part of the bill because it's interesting and needed.
Thank you very much, Madam Chair. And I did speak pre-session with some, including the Composite Medical Board, about the other part of the bill, and certainly support that as well. What we've been working on is really a workforce issue for our physicians and our PAs, AAs, and protocol agreements with APRNs that go through the Composite Medical Board. We've had a system that's pretty antique, and I think the Composite Medical Board has started working aggressively on a new system. The system now, for instance, won't even tell you if you're deficient in something. It doesn't kick it out like you think it would. So the software is actually already being customized for Georgia. There's no procurement necessary. That's already been done. This has been going on for the last year. Simultaneously, we were working in Northwest Georgia with Dr. Paul Brock, who is the Dean of the Medical School for Augusta University for Northwest Georgia, with medical students. They were our guinea pigs. And they're going to 15 hospitals. They're sending their transcripts 15 times, criminal backgrounds, all this paperwork over and over, hundreds of dollars each for them. And with some AceMap software, combining with the ThoughtSpan that is the Composite Medical Board, we now have them where they're credentialed everywhere in those hospitals. If they're credentialed at one, they're credentialed at all of them. My own example, I tried to retire a year and a half ago from anesthesia and still work part-time. There's such a shortage out there. They're making it pretty attractive to still work some, so I still work some. But the hospital a couple of miles away wanted me to help them out, and I said, yeah, I can work a little bit. Perfect record, no issues ever in my career, knock on wood if I can find some. But, it took me 3.5 months to work in that hospital with an absolute perfect record, and I've got connections. There's people that take 7-8 months for the same thing. So the system in place that the Composite Medical Board will be using and is customizing, we feel like, looking at some other states have used it, this is proven in other states, that we should be able to, and sometimes I confuse licensing and credentialing, so don't let me do that, but we can license them within a couple of weeks. The Georgia Hospital Association and the CEOs who worked with us on the medical students are looking at that if you're credentialed in one, if we've got the same criminal background check, we've got the same paperwork and all like that, that you can be credentialed everywhere. Any hospital has the right to add additional requirements they want to, but we feel like we can move it to within a couple of weeks, 30 days at the most, to get somebody ready to work in another hospital. You try to hire a doctor from out of state, and then or it could be a nurse or something, but you say, okay, well, we'll see you in 7 months. Well, they don't want to come work there. And you hire somebody. We've got somebody going on pregnancy leave, so we're going to get somebody in here. Well, the baby's 3 months old by the time we get them credentialed in the place. So we're trying to bring Georgia up to the standard of some other states, and this is going to help us attract people from other states who can come work here much, much quicker. And so then they don't have to think, you know, I can go work in this state in 2 weeks, or I can go here in 7 months, or sometimes it's been over a year. We can speed that up, and it's going to provide a better workforce, larger, because we'll be able to attract people from other states, and a much quicker workforce to where you can look on there and say, I'm credentialed here, they got a problem over here, I can come help you next week. That's the goal of this that we're working on. I think it's going to be a good system, and I would like to take credit for it, but other people, including the dean of the medical school for Northwest Georgia, put a lot of work into this and have gone through. We actually worked not with the attorneys in the hospitals, but the CEOs. And the CEOs, one other thing I'll add quickly, the CEOs said, we'll change the bylaws if we have to for these medical students. We did not have to change a single bylaw in any hospital to make it work, which was amazing to me. So I think this is going to be a good system, and I'll answer questions, or I'll be quiet and let the second half of the bill be presented.
We just had that last week. I don't think I really need to present it again, but we'll ask you questions, and then if anybody wants to ask me a question about the other, I will answer it. Okay, we have questions. Representative Oliver.
Thank you. I'm happy to support this bill. We gave $2 million last year to the Secretary of State, which I know has a different crowd of licenses.
Mm-hmm.
And so there's a collection of vendors that's doing this to bring it into the modern world. Are you thinking, the people who are making these decisions about vendors, are they aware of what vendor Secretary of State's using and how this is being maybe coordinated for all the
I don't know that they're being coordinated, and we sort of split duties on the Senate side. I know somebody's working on the Secretary of State on the House side. We split it up. I really didn't want the Composite Medical Board to get caught up in multiple licensing things from the Secretary of State, so we did this path over here. I thought it was a simpler path, but the same thing certainly needs to happen over at the Secretary of State's office.
It's a major licensing bill chaired by Senator Tillery and Representative Hatchett that they're passing. I think it's going well so far.
Yeah.
That's trying to do some of this modernization. So I just
yeah, and we're on dual paths, and I hope they are successful. I really feel like this is going to be successful. Most everything I do, it's not because I had a great idea, it's because I found another state where it works. And those always seem to do better than my bright ideas.
Other questions for the senator? Okay, I see no questions for the senator. Is anybody from the audience that wants to speak to this bill? Okay, hearing none. What's the posture? Does anybody need to ask me a question about the other part? That is the part about the clinics that are popping up using, right now, the ketamine offline, and basically, they're, I won't call them pain clinics, I almost call them addiction clinics, because they found that if you mix the ketamine with other drugs that they're taking, you get a higher fund from it, and also you run a bigger risk of dying from it. So this is a real problem. Representative Cannon.
Thank you. I was not present at the discussion of this, so thank you for allowing me to ask this. In my understanding from line 44, what it describes clinic, and then at the end, line 122, so where will these services be rendered? It seems as though it's only in standalone clinics. It's not in hospitals that have clinical trials or that.
It isn't, yeah.
Okay. And so my question is, what's the reasoning around that?
It doesn't limit to that in the future, but it's saying right now, how they're using it at the hospitals and how any clinical trial, this bill does not interfere if the hospitals are using them. So So if we have clinics in the future that the medical board will put the rules and regulations about how you would have to qualify to be a regular clinic outside the hospitals and so forth, and they would regulate it that way. Does that get it? So, I mean, I suppose that you could have a psychiatrist set up a clinic in the future. Sure, Dr. Al.
So just to fill you in on the conversation from last week, so ketamine, if we're talking about ketamine in specific, is a dissociative anesthetic, so it's a very powerful medication that we will often use in the hospital to induce anesthesia or for pain. I think that what this bill aims to address is the off-label use of often infused ketamine for pain or psychiatric conditions or other conditions that is much less regulated than probably the state would like. So this is looking to bring up those safety standards to par. Mm-hmm. So it doesn't affect on-label use in a hospital or in an OR.
Okay. Representative Seabaugh.
Question, but at the appropriate time.
This is the appropriate time.
I make a motion to do pass.
Okay, we've got a motion to do pass in a second. Any further discussion or questions from the members? No? Then everyone in the favor of the passage of the substitute to Senate Bill 162, say aye. Aye. Anyone opposed, no. Okay, so the ayes have it. And Senator, I hope next year you will be back with a bill that will do the other part that you want done so that doctors can be credentialed only one time. And
Well, we think we can do it with this.
this one, you think that'll be
Yeah, we
enough?
think so. It's up to the hospitals, and they've been supportive of it, so I think they're going to do it. I should have added that there is going to be portals in this software to where hospitals will be able to, if they've got additional requirements, we think they're going to be able to enter it in there as well and basically be one-stop shopping.
Okay, great. Well, if you need to make any adjustments to that, just bring it back to us next year.
Thank
That's
you
going
very
to be
much.
one of the, I think that how long it takes is one of the biggest deterrents we have for getting doctors and PAs and nurse practitioners into our state from other places. We hear it all the time about how long they have to wait. And if you're waiting to be credentialed by the hospital, that if it's just even one, then you don't have a job till you're credentialed. And if it's 7 or 8 months, then people will find somewhere where they can make a living in another state quicker. Thank you very much for bringing the
Thank
bill.
you.
And the committee will know this is the time of year that bills do get attached and combined, and I appreciate the senator working with me on this one. Thank you very much.
Thank you.
So, okay. There is a rules, Senator, there is a rules form. Okay.
We'll get it filled out.
Right, I think I have to sign it. I'll be here tomorrow, or,
Make sure we get my aide to get it over to you to get signed.
okay, right. And if it's there this afternoon, if you go back to your office now, I'll sign it and turn it in.
All right, even better.
Thank you. Okay, all right. I'm going to let the people that we have from the Georgia Trauma Center go first. And so, Dr. Ashley, you're on. Thank you. We got it. We do this every year for the committee and new members to the committee, and we've made a lot of progress in making sure that in most of the areas of our state, if you have a terrible accident, that you can get the medical care you need within an hour, which is often decides whether somebody lives or die. And we all owe Dr. Ashley a great big thank you for all the work that you've done from the very beginning of this commission and starting to coordinate the care for people across our state that are injured in accidents. So you've got it, and you've got the floor.
Okay, thank you, Madam Chair, and thanks to the committee members for being here. And this, really, I listened in on your previous meeting where you voted on the budget, and I felt tired after listening to that discussion. I can't imagine how much work went into that, so thank you for what you do. And that's really a tie-in to what I want to do today. I'm not here to ask for anything, and so really what I want to do is thank you and for what you've done. And we have a success story about how what you do really matters at the clinical level. And so what I want to do is take you on a journey through what you've done by working with the commission, what we've done at the commission level, identifying areas of quality that needed to be addressed, and then drill down to actually how that looks once you get away from the capital in South Georgia in a rural area, and how that affects patient care. So we're going to start high, and then we're going to get down to where the rubber meets the road on how that affects patients. You have this in your packet, so you can flip what I'm flipping through with the slides here. Each page.
On the side there.
Oh, it's on the side. Okay. Each page we'll see here. So if you'll just sort of go to the map there, you can see this is where we were. Just to refresh your memory for anyone that's new on the committee. Trauma access in Georgia in 2007. You can see the little dots on the left of the map there. Those are trauma centers. The gray areas are 60 miles or 60-minute timeline, if you will, to get to that trauma center by ground. And you can see we had a lot of white areas in Georgia in 2007, or gaps in coverage. If you fast forward to 2025 on the right, you can see there's more dots, which represent more trauma centers. And then there's more gray and less white, which is good because we're covering more of the state. So we've made significant improvement working with you, the legislators, over the last several years. If you go to the next slide, you can see a timeline. I won't walk through all this. It's in your packet. You can have it if you need to refer to something, but I will point you to the far left. You can see when we started in 2008, we had 15 trauma centers circled in red, and now we're up to 35 trauma centers. So again, that's why that area of the map is becoming less white and more gray, because we've increased the number of trauma centers. If you see the dotted line there to the left, you can see that little dotted line around 2014. You can see we formed the Georgia Trauma Quality Improvement Program Collaborative. That's a mouthful, but what that means, next page, is that's the Georgia Quality Improvement Program, and you can see it's been in existence when we formed it in 2012. We started with 5 Level 1 centers and 7 Level 2 centers. We meet twice annually in face-to-face meetings, and we form various work groups when we decide there's quality issues that we need to address as a state. And you can see now we're inclusive. We have all levels of trauma centers, including pediatric centers and even our burn centers. So everyone's at the table to work on quality. If you turn the page there, you can see this is what a quality report looks like. We group all level 1 and 2 trauma centers into one big trauma center for measuring quality. And we compare ourselves with about 650 other trauma centers across the country. And we get twice a year, we get a quality report. And as Liz Atkins, our executive director here to my right, says, you don't have to be a statistician to know that red is bad. So we had a lot of red diamonds on our 2015 risk-adjusted hospital events report. And what that means is in the hospital, we look at various things like DVT or blood clots. We look at kidney injury and just ventilator-associated pneumonia. We looked at a lot of things to follow quality throughout the hospital. And what we found is, as a group, when you pooled all the trauma centers together, we didn't look so good. So the Trauma Commission said we need to do something to improve our quality. So next slide. So as we looked around, we were all well aware that the American College of Surgeons verification process, you might call it certification process, but we use the word verification. If you become a verified trauma center through the national guidelines of the American College of Surgeons, we know that those trauma centers get better, their quality gets better. That's well proven in the literature, and I've just listed a couple of articles here to show that. But there's no data to show that this works at a statewide level, that the verification process, the tight quality metrics that the college puts in works when you look at all the trauma centers combined into a state collaborative. So we put together a project, the Trauma Commission did, and we proposed a solution. We hypothesized that requiring the American College of Surgeons consultative and subsequent verification for level 1 and level 2 trauma centers would improve state collaborative outcomes. So this was a rather long project. You can see it took several years to complete. But here's the timeline on how that looked. In 2017, we required all trauma centers, level 1 and level 2, submit an application. We started very slow. Just submit an application to the American College of Surgeons to come down and do a site visit. In 2018, the trauma centers were given 5 years to achieve ACS verification or certification. And then in 2023, centers were required to achieve ACS verification by June 30th if they wanted to continue to receive Trauma Commission funding, i.e. legislative funding, because our funds come through super speeder through the legislature. So then next slide, ACS consultation verification progress. You can see in 15 when we started, we already had one center that was verified through the American College of Surgeons as a level 2, and we had 2 centers already that had consultative visits. So we had a little bit of a start, if you will, in 15. In 19, all level 1 and 2 ACS consultative visits were completed. And what that is a mock visit. In other words, they come in, it's very non-threatening, low-key. They look at everything and see what metrics you don't meet and what you need to do to have a successful verification visit. So this was a mock visit that the commission paid for so all centers could be successful. And then finally in 2023, 11 of the original 15 centers achieved ACS verification. And I'm going to walk through what that looks like now, the little journey. So, and again, realize this had not been done before at the state level, this massive of a project, if you will. So,
Can you stop just a minute?
Yes, ma'am.
Tell some of the members that they don't know, what makes a level 1 and what makes a level 2?
Thank you, Madam Chair, for that question. Excuse me for not saying that up front. A level 1 is the most comprehensive. It differs a little bit if you flip back and forth from OB to surgery. I guess we had to make it difficult for everybody. But anyway, a level 1 visit is what you might think about as like your Grady, Navison Health in Macon, Savannah, all the trauma centers that are level 1s. Most comprehensive care. And then to a 2, to 3, to a 4, a level 4 would be maybe a very rural hospital, doesn't even have a surgeon, maybe a very small hospital, but they do have an ER. They can do some life-saving interventions in the emergency room and then very quickly transfer that patient. So a front line, if you will, emergency room or trauma center.
So the level 1 would have on hand 24 hours a day. Is it still that way?
Yes, ma'am.
Every kind of surgeon you possibly need.
Yes, ma'am.
Neuro, for all the systems and anything you would need. And then a level 2, what makes the difference? It's not a teaching hospital or?
A level 2 is clinically the same as far as the subspecialties that you must have, but you must also do education and research. So there's a very strong research component and education reports.
For the level 1s?
For the level 1s.
Okay, thank you. I'm sorry.
No, thank you. That's a great question. And so then, just to show you the timeline there, going from 2015 from your left all the way over to the right in 2019, you can see for consultative visits in green, you can see we had a very methodical approach, just a very slow approach until we got all the way over to 2019. You can see 14 of the 15 centers had a consultative visit. Remember, 1 already had a visit, so they didn't need to do it again. Then if you look at the next page, as far as the verification process, you can see we had, again, a very methodical approach across the page. You can see at around 19 and 20, we sort of plateaued, but if you remember, that's when the pandemic hit, so we had to work through this project through the pandemic, which had its own set of challenges, but we were able to do that. And you can see all the way over to the far right, 11 of those original 15 centers achieved ACS verification. So to sort of show you what happened, next slide, what happened to those centers that did not achieve verification. Of the remaining 4 centers, 2 level 2 centers right-sized to level 3 designation. We think that was a good thing in the sense that they were struggling, if you will, to meet all the resources and quality metrics that a level 2 center should have. So when they fit into the level 3 category, they became very high-performing centers, what we call right sizing, which again is good for patient care. It's also good stewardship of our funding, because if you're paying for a level 2 center, you want all the resources that a level 2 center has. So it's a right sizing also for the legislature and our funding, as well as the commission. And then you can see one center voluntarily withdrew from the system, and the hospital subsequently closed, so that had nothing to do with the actual the process for what the commission was analyzing there. And then only one center was not able to fully achieve ACS verification. So next slide, did it make a difference? So fast forward here now, remember on your left there is the 2015 report that looked bad. All the metrics were in red. And then if you look at the 2023 risk-adjusted report, you can see all the diamonds turn black. And we could talk for hours on these, and I know there's some folks in the audience that might want to do that. But for the sake of time, I'll just move on and say red to black is a positive, so our quality metrics greatly improved. Next slide. I'll leave this one for you to read about, just some considerations in your packet. Talks about the pandemic and so on. But in the interest of time, I'll go next slide to the key takeaways that I'd like you to take home today. Implementing a statewide requirement for American College of Surgeons consultative and then subsequent verification visit can be achieved. This was a massive project that was achieved throughout the state. So this is the first paper in the literature that's actually coming out this month in the Journal of Trauma in print. It's been online. You can actually get it from a couple of months ago that was published online ahead of press. So the process works at a state level. And then the TQIP, or the Trauma Quality Improvement Benchmark, performance improved significantly over the period from pre-ACS to the end. So again, what this means for us is that we identified a problem, we instituted a solution, we followed the solution to see if it worked, and it did. And obviously, as I have to sit here and report to you and your authority, as you have to report to your constituents, we need to be reticent of the fact that if we're spending tax dollars, it's making a difference. So next slide. These are some benefits beyond verification this was a grassroots effort. The American College of Surgeons verification requirement was recommended as a formal motion by one of our committees. So basically, the commission doesn't just sort of sit in the ivory tower and mandate things that all trauma centers and EMS need to do. We get feedback from our subcommittees, just like you get feedback from your committees, and then we implement processes that hopefully make a difference. We also found synergy. Only half of the centers achieved verification by 2019, but all centers' reports were already improving. So the halo effect, if you will. And then right sizing is key. We came up with that terminology, if you will. 2 level 2 centers voluntary transition to a 3, which was the right size for them, and it ensures funding is responsibly allocated. So next slide. Again, as I alluded to, the work is available online. And I'd like to thank all the trauma centers that were involved in this. The commission is giving the report today, but obviously we're nothing without our partners, and they're listed here. Now, that's at the state level. That's at the legislative commission level. So now I want to drill down a little further to show you what that looks like in South Georgia and what it looks like with patient care. And this is a great story. And again, I want you to realize what you do in this room, which can seem sort of sterile and separated from reality, if you will, is what goes on at the patient level. I want to bring that home now and let you see what it really means. And so we are so thankful for what you do, and this is why. So I'm going to turn it over to Emily Brown now, who is the Director of Trauma and Emergency Medical Services at South Georgia Medical Center. Emily?
Good afternoon. Thank you, Dr. Ashley and Liz, for allowing SGMC Health to present this during part of your time. So just a little background about SGMC Health and our trauma. There you go. We did become a state level 3 designated trauma center in June of 2023. There is a little map there on the side that just highlights kind of our immediate coverage and referral area, which does cover about 1,589 square miles. There's about 160,000 population that we serve. And just to note, and this will become important later in this presentation, but we are about 120 miles from the nearest level 1 trauma center, and Dr. Ashley did a great job of explaining the difference. We are a level 3 trauma center. Our closest one to the north is Macon, and then our closest one to the south is UF Shands in Gainesville, Florida. So we still are about 120 miles from either of those, which is a long way by ground. So we depend a lot on transferring our patients by helicopter, which many of you know in South Georgia is not always feasible with our weather. We do see a little over 1,700 trauma activations at our facility, and 112 of those are considered level 1 trauma activations, which are your more severely injured patients. The case that we're talking about today, this was a vehicle accident in very rural Brooks County in South Georgia, and it happened early on a Saturday morning, about 7:30 in the morning. The patient was a 58-year-old male, and he was traveling with his brother, and he was the front seat passenger in a truck. And they went through a stop sign, and another full-size truck that was pulling heavy equipment hit them on the passenger side. The impact was so severe that it was complete intrusion into the passenger compartment where he was riding, and it completely folded his passenger seat in two. When EMS arrived on scene, he was already out of the vehicle before they arrived, but I'm not sure if you can tell in the pictures, which is also important, this was very foggy. It was very foggy on a Saturday morning, and this would have been a very good opportunity for EMS to be able to call a helicopter to land there on the scene, but the ceiling was about 700 feet with the fog, and so there was no way to call a helicopter to land there. So they did have to make the decision to treat the patient on scene and then decide which trauma center to take him to with ground transport. Brooks County is between Lowndes and Thomas County. There's a level 3 trauma center in Thomas County, but we were about 18 miles closer, so they did make the decision to bring the patient to SGMC in Valdosta. Our emergency room did receive notice that they were coming in with this patient. We did get the level 1 trauma activation. Trauma activations for a trauma center are a requirement, and this is really what sets us apart from a non-designated hospital as a trauma center, because these activations require us to assemble a team, and we assemble this team before the patient arrives as soon as we receive that activation. Part of our level 1 trauma team is going to be a surgeon, an ER physician that's board certified in emergency medicine, experienced trauma nurses, OR nurses. We notify our blood bank so that we can have emergent blood in the trauma bay before the patient arrives. So we received the notification for this patient at about 8:15. So we assembled our team. We activated our team at 8:16, which means that the notice went out a minute later. The patient did arrive at our facility at 8:56. And we began immediate treatment of this patient, but he had was already within that 60-minute golden hour. So we were immediately treating this patient who was severely injured. And about 17 minutes after he arrived, despite our efforts and interventions when he first got there, the patient did go into cardiac arrest where he lost a pulse. So we had already started emergent blood transfusion on this patient. A surgeon was already at the bedside. We did have to insert a tube into his airway to put him on a ventilator and breathe for him. And we also were in the process of inserting tubes into his chest to drain any blood out of his chest. And we continued to do this the entire time he was in cardiac arrest. We continued our blood transfusion. And about 18 minutes after he went into cardiac arrest, we were able to get a pulse back. Once we got that pulse back, we were able to stabilize him enough to get him to our CT scanner, where we knew that we would find severe injuries, and this CT scan does highlight those injuries. He had several liver lacerations. He had spleen lacerations. He also had blood in his chest, which we had already placed some tubes, but we had to bring him back later and place additional tubes to drain the remainder of that blood out. He had a pretty significant right kidney laceration, and you can see there on your paper the kidney that's to your left, but his right kidney, there's a lot of haziness around that kidney, which indicates the blood. And he had bleeding behind that right kidney, which is very difficult to stop without a specialty surgery, interventional radiology, and we do not offer that at SGMC Health 24/7. So we knew that this patient needed to be transferred expeditiously to a level 1 trauma center so that they could intervene on his behalf to stop that bleeding. We did return him to our trauma bay from the CT scan and place that additional chest tube into his lung to drain some more blood there. And it's important to note for the next hour and a half, the patient was not stable enough to go in an ambulance on that 2-hour ride to Gainesville, to a trauma center. And we were making multiple attempts to try to get a helicopter to come and get him from our hospital. We're unable to do so because of the weather conditions. Because we had to wait so long to try to get a helicopter and we just were not comfortable putting him in an ambulance and taking him by ground, at about 12:40 we realized that the patient was decompensating so much so that we had to take him to our operating room with our surgeon and do what we call damage control surgery. Our surgeon, we had 2 surgeons that took him there. We're very fortunate at our hospital to have surgeons that are able to do that type of surgery. Our OR team had already come in for this patient, but that type of surgery in a rural hospital, it takes a lot of staff and equipment and time to be able to do that, but we do offer that there. So they took him to our operating room, and what they did was a laparotomy, and this is a surgery that just opens up the entire abdomen. Whenever they did open him, they found that he was bleeding basically from everywhere. They had to remove his spleen. They were able to repair the liver lacerations, and then in order to be able to get him transferred to a level 1 trauma center where they could perform the additional surgeries, they basically packed the inside with sterile washcloths or wound packing. And they left his abdomen open. We cover that with a large plastic piece of equipment that's called a wound vac that'll drain all that. But we knew that they were going to have to do additional surgery for him whenever we transferred him. This patient had already been accepted at UF Shands before we took him to our operating room, but again, we had to do this initial surgery so that we could get him potentially stabilized enough to be able to transfer him out. We did think that whenever he was done with recovery in the operating room that we would have a helicopter that would be able to get him, and they told us that they would be on the way. So we made the decision to take him back to our emergency room from the operating room, which is not typically your process. We did that because it's close to the helipad. And once we got back to the emergency room, the helicopter called us back and told us that they were unable to come because of weather. They had to turn around. So we spent additional time on the phone back and forth with them, trying to get them to come and trying to figure out different ways that we could get a helicopter there. This patient did happen to be a member of the public safety family, so there were lots of people there that were involved in this. We discussed using a Georgia State Patrol helicopter that could fly in additional, inclement weather and different things like that, but it just never really worked out. The patient was just not stable enough to do that. Once we got him back to our emergency room, the flight was canceled 3 additional times just due to weather or mechanical issues. And so we did have a critical care transport team that was from our facility that had been assembled for some time. And we made the decision that we would just go ahead and take him by our ground transport. And when we were loading him up in the truck, they called us back and said, our other helicopter can come. They're back at base and they can come. So we made the decision to wait. And UF Shands came and got him. But he was from the time he was discharged from the operating room back to the emergency room, that was an additional 3 hours that he was at our facility waiting on transport. His total time at our hospital was 8.5 hours before we were able to get him to a level 1 trauma center. And it was just the difficulty in trying to find transport and getting him stable enough to be able to do that. To note, we had to give him 67 units of blood product while he was at our facility. That's over 16,000 milliliters of fluid. We replaced his total blood volume in his body nearly 3 times. This trauma centers are mandated to have a mass transfusion protocol, and this is something we put in place at our facility when we started our trauma designation process, and something that we work on, and we still work on that. We build on that. but very proud of that program. Without that process and protocol in place, we would not have been able to do this and actually be able to transfer him successfully to a level 1 trauma center. We have continued to build on that. In fact, in February of this year, we placed blood products in our trauma bays so that there's a 0 turnaround time from an emergent patient being received in our trauma bay to the time that we have to start a blood transfusion. And we also have just recently completed the training necessary for our EMS staff to be able to put blood on their ambulances so that we can start emergent blood transfusions in the field. We were able to successfully transfer him out after that 8.5 hours where he was transferred to UF Shands in Gainesville. This patient underwent multiple surgeries at this level 1 trauma center, but after about 45 days, he was actually able to be discharged from UF and was transferred back to his hometown hospital, which is Fairview Hospital, for inpatient rehabilitation. And then on April the 16th of 2024, he was able to return to work. Captain Bracewell has been a longstanding member of the public safety family. He's touched countless lives with children that he's worked with through the DARE program in his hometown there. Those children even welcomed him home when he got back to that hospital and came to see him. And I think they even had him a surprise birthday party after he was able to go back to work. Just a year after his accident, which is not good for my anxiety, he let me know that he was back to flying in his plane, which is where he was headed to that morning when he had an accident, and is back to riding his motorcycle. And just as an additional way for us to thank you for all your work that you've done for the trauma centers, we have Captain Bracewell here today in the audience.
Would you like to say anything?
Yes, I do. First thing I want to do is thank God. Forgive me if I cry, but I just can't help it.
It's okay. Real guys cry.
I had a lot of support, and you know, God's up here for me. Emmy Brown right here, she's right up under him. My wife right here, don't forget her. But you know, Emily, she saved my life really, just on her actions. You know, every time I hear what I went through, I learned something new. What I had to happen to me. I'm gonna go ahead and make y'all bored and tell you the whole story. It all started with a cup of coffee. Me and my brother, as she said, we was going down Thomasville to fly in, to have every year. We stayed at a friend's house, and he brought us 3 black cups of coffee that morning. I looked at him and I said, I don't drink black coffee. My brother Danny said, what do you drink? I said, I drink Circle K coffee. Well, we was looking for a Circle K when we had our wreck. My brother, he was trying to look after me. Anyway, y'all know we didn't find a Circle K by no means, but I don't. You know, they asked me what happened. I can't remember the day I left PAC. The first thing I remember was waking up in Shands. My arm was tied, and I'm wondering, what did I do to deserve this? And you know, I really didn't realize what had gone on. My daughter and my wife was in there, and they said they were trying to calm me down. They said, Daddy, you have ripped your stuff out, and they had and my daughter said, well, if you'll take it off, I'll keep him calm. From that point on, you know, it was a long road, I'll tell you, it was a long road. But I can tell y'all, I never really felt any pain. That was God's blessing to me. But when I got home, it's unbelievable, the people that care about you. I had probably 100 people in my yard. People at the hospital, when I left the hospital, my sheriff, he was very supportive of me. He's supportive of me now. He's put me back to work light duty. And, you know, you can't ask for anybody or any community to support anybody as much as they supported me. And that's very much appreciated. A lot of blessings, God's blessings, a lot of prayers. People prayed. Every time I see people, they'd ask me, how are you doing? You know, it's just amazing how people can come to you when you need it. And I needed help. I really did. Still need help. But either way, I'm going to get through this. I'm determined. I wasn't able to walk until I got to Fairview Park Hospital. And probably a couple days after I got to Fairview Park, a little guy by the name of Nilo, he's doing physical therapy there. He come and grabbed my bed, and I said, you know, and I told him, I said, I want to walk. And he got me walking. And he held me to his word. He said, Nilo talks, people walk. And, you know, he held his word. I'm walking. I walk like an old man, but it's better than not being able to walk at all. And, you know, things I can tell y'all a lot of things that's happened to me and bore y'all. But it meant a lot to me for all these people to do these things for me. That little lady right there is the reason I'm here. And I really, really appreciate it. These trauma centers, you know, we can spend all kind of money for trauma centers. And maybe 9 out of 10 people make it, maybe 9 out of 10 people don't make it. But I'm one of the ones that did make it, and I really appreciate that. I mean, you know, it's just amazing. It's amazing to me. I walk outside, even in the shape I'm in now, and I thank God I'm here. It's just amazing. One other little quick thing. Me and my brother was going to therapy one morning, and he always stopped by Circle K. I always stop by Circle K to get coffee when I go to work, whatever. But he would stop by Circle K with me. And I got in that morning, put my cup in that cup holder. I looked at it and raised it up, looked at it. I said, you know, that's about a $777,000 cup of coffee right there. He just looked at me and nodded.
Well, I thank you for telling your story, and I'm very glad that you survived.
I'm sorry.
I'm a true believer. They talked about your service to your community and children. The good Lord wasn't ready to let you stop working and giving to your community, obviously.
Yes, ma'am, I believe that.
And-
I really do, and I thank you.
Like that.
You know, these kids, I've been teaching DARE, or CHAMP, since 1996. I've been in my department for 37 years. I've been through 5 sheriffs. I told the last one, I'm tired of training sheriffs now, I'm through. And, you know, he's been very good to me. All my sheriffs have been good to me. But the last one's been very good to me. He's looked after me. He was at the foot of my bed one day at the hospital. He said, Bracewell, yes, sir, don't run for sheriff. Everybody I talked to asked about you as a sheriff. I'm going to run from the sheriff. I'm not running for sheriff. But he has been real supportive of me. And Chief Deputy Stan Wright, he come when I was not able to drive, he come get me and take me to work and bring me home every day. You know, people like that makes it all worthwhile.
I wish I could bottle you up. You know, we have trouble recruiting doctors to go live in small, rural areas across our state.
Well,
And I think you are a good example, and what this hospital has done and the work of the Trauma Commission, it just shows there's a different way of life in these areas. It's a little slower. We know more of our community. It's a good way of life, and I wish we could bottle that up, and I think a lot more doctors would decide to do rural medicine and really see how wonderful it is to live in some of these small areas across our state. I came from a rural town in Texas and have a little bit growing up and know how great that was, but have become a big city girl because my husband was a doctor in the big city. But thank you again. We have questions. Are they, Representative Sharper, did you have a question in general? Or?
Yeah, just quickly, I'd like to just say thank you so much, Doctor, and also Ms. Elizabeth and Emily. And basically, Valdosta is where I started my journey, you know, EMS, paramedic, about 36 years ago. And I can truly say that I've seen the great work, and it's continuing to getting better and better, not only the hospital, but the EMS, and we have some of the people from South Georgia here as well with us, some of the training officers and people that really work hard. I can just say that they work really, really hard, and we appreciate it, and I appreciate y'all driving all the way from Valdosta and other places. So thank y'all so much. I appreciate you.
Thank you.
Dr. Al?
Thank you so much for your presentation. I'm so glad that you're here. to talk with us today.
Me too.
I think that this presentation really highlights a couple of things. One is obviously the importance of high-quality, timely, well-staffed medical care. And the second thing I just want to highlight is the importance of having blood products to give, right? I can't help but notice that you received 67 units of blood, which is an incredible amount. I know that was over
I
several
wasn't
weeks
making it
probably.
when the doctor, my white counts went way up, and he looked at me, he said, "Have you ever been checked for leukemia?" I said, "Look, if I got leukemia, it's the blood y'all gave me, it's not mine."
And, I can't help but to note that like a trauma center cannot run without blood. Cannot do it, right? And I hope that not many people have been in the experience of having a patient in need of blood and not have any to give, but there have been moments recently with our blood supply shortages where that has in fact been the case. So I would encourage people to donate blood, and note that our next blood drive at the Capitol is actually on Thursday, which I'm hoping might be a lighter day, so it's a great day right before the weekend for people who are able to, and I know not everyone can, but if you can, to donate blood, because every unit of donated blood actually has the capability, when spun into its component parts, to actually help 3 patients, right? So we can be part of this great story that we're hearing today and help patients pretty easily.
I'm sorry, Representative Seabaugh.
Thank you.
Thank you so much, and what a great story. And I too am not one upping you, Representative, but I've been in EMS for 40 years. I worked in rural EMS, and I worked here at Grady for a number of years as a paramedic. And we rarely get to see our patients after we drop them off at the ER and see the final outcome. So it's always great stories when we get to see the results of all of our hard work and the training that we put into that. And I see my good friend Terry Cobb here from South Georgia. Appreciate all of my first responder brethren being here to hear this great report. I want to ask Dr. Ashley, I see that we put $1.85 million into support EMS education. What kind of, just explain to the committee what kind of education that we're able to provide our first responders through the Trauma Commission?
So there's a pretty robust education process that with a lot of different type courses going out, and it can be everything from management at the scene to leadership classes to where we're grooming, not so much me, but the EMS committee is grooming the future leaders, if you will. So we can actually get you, there's so many courses. We have maps. Liz, our executive director, who I forgot to introduce, I always do that. She'll hit me in the back of the head when we leave, but no, she's really nice. But we can get you maps to show you where those courses are, and we have all that data. So maybe, Liz, we could get that for the representative. Okay.
Well, Dr. Ashley, we've been doing this for a lot of years. You come in once a year. And I tell you, knocked it out of the ballpark. Thank you for this story. I mean, they say a picture is worth 1,000 words. A picture and hearing the result and having the person that was survived, because that hospital was ready, a level 3, but they had the team that was ready. They knew when they got the call what to do. They had the blood available. And, that gave him a chance of surviving as badly as he was hurt. If this had been how many years ago? 15 or so?
If this had just been, if it had been just before, if they hadn't been, I'm going to make a bold statement here, but it's true, and I have the mic, so I'm going to make it anyway.
Okay.
But if they had not have stepped up to the SGM, they're a good hospital. I know the surgeons there. I know the hospital. They're a good hospital. They've been for a long time. But if they had not have made the commitment to be a trauma center just recently, he would not have survived in their routine hospital. And because they wouldn't have had a massive transfusion protocol, the teams wouldn't have been rehearsed and ready to go, and he would have died in the ER. They would not have gotten him back. And 67 units of blood, I know you don't really have a tree to really hang that leaf on if you're not working in a trauma center, but to give you an idea, 67 units stress my level 1 trauma center. I mean, we have a lot of blood, and we're a 600-bed hospital. The fact that they can pull off 67 units in rural Georgia,
Right.
wow, we're making progress. And that's what I want you all to hear and understand. We're making a difference here. And this is what the difference looks like when we sit here and just talk about paper.
And how many beds does the hospital have? How many beds in your hospital?
We're licensed for about 289.
289 beds.
Yes, ma'am.
A lot of difference from 600 in a very busy city with lots of people to donate blood to have it
Yes, ma'am.
have it ready. I don't know how many members are new, but if you look at the map in the folder where they showed these centers, when we started this, if you got past Macon on Highway 75, there was almost no chance at all of being within an hour, that golden hour of surviving. And when this started, and I certainly didn't start this, but I was a big supporter because I had a husband that twice a month drove once first to Albany, and then for a while to Waycross, and then down to Lake Park. And every time he left home, I worried that, in his station wagon, that he would get hit and there wouldn't be able to get him to care, and the kind of care he needed in time for him to survive. And we've really cut that in half. What area still needs it? You know who I'm going to ask about. Okay, how about PB Putney, or whatever it's called? Do we still have, are they coming aboard? I know they said they were trying the last time I saw the CEO.
So they've made significant progress, and they're become designated as a state-designated Level 2 trauma center now, and are doing a great job. And they are, I believe, going for verification through the American College of Surgeons sometime next year. So
Great.
So we're making progress. And so, Madam Chair, when I can report to you that has happened, obviously it's a great day now being designated. So we'll have a party.
Okay, and that's truly because that area is so much of the part covers so much of the part going toward Alabama, and that there was just nobody there and no help for people. I mean, you left Macon and your life was in your own hands at that time. One of the things I wanted to ask about, and then I've got a couple more questions. When this was going on, were you calling, doesn't the trauma center have a control system? Did I miss this or understand where, when you were making the decision of which hospital to get to, the ambulances were deciding, do they check in with the control center in Macon and tell you whether their emergency rooms were open, or do we have that system in place where we can tell if they need to be air flighted somewhere, whether they'll take them at Sands or they have to air flight them over to another center?
We'll tag team that, but just to start at the state level, and then I'll let Emily get down into the weeds with the ER level. There's no state system for coordination of care, so there's no number you can call and say, I'm in region whatever, and I need to go somewhere. Who's hot and who's not, who's on diversion, who's not. We don't have that system currently.
Is that something you would work for in the future?
I would love to work for that with my legislative team. I have great ideas, and we have solutions from other states, so absolutely. We need that. I'm being a little bit funny because there's a lot of history there, but we need that. Other states have it, and that's really the next frontier that we need to solve.
And that would really be the first responders that got to a wreck would be able to tell and not waste time driving to the nearest center if they were not capable of taking care of the person, or they were on diversion or something because they were so busy. And it would
right.
Really,
if you had options, you could build it in the system where the paramedics could know at the scene. If you didn't have options and there's only one hospital to go to, that hospital could have a number to call and say, where's my closest place that's open or that has my needs. I need an orthopedic surgeon, or I need a neurosurgeon, or they could very easily, with the technology we have now, it's very easy to do.
Okay.
So I will say from an ER perspective, we have good relationships with our Level 1 trauma centers. Typically, when we call those Level 1 trauma centers and we need to transfer a patient, they will take that patient typically with no pushback. Rarely do we get we absolutely can't take them because of a diversion issue with a Level 1 trauma. A standardized system absolutely would decrease a lot of the extra phone calls and time that requires to make those calls and get acceptance. There's several phone calls that go along with that. But we do have part of the building the trauma system in Georgia is to have good relationships with those trauma centers and to be able to get those people on the phone, and they typically accept without an issue.
Okay. Well, when you get things settled here and you need something to work on, you might want to come back to us with a request for that. Representative Cannon.
Thank you, Madam Chair. Thank you for your work as a Phoebe Putney baby. I'm super happy that they have, opened their trauma tower and they have an NICU, and I think they're, doing great work. I just wanted to ask about incarcerated individuals. What do you do in situations where there might be a traumatic incident in a correction facility? How did those individuals get care? Thank you.
So basically, that's up to the particular facility, and I don't know exactly how they choose, but I know I get a lot of folks that are incarcerated, and they come by ground and they come by air. So whatever mechanism they get there, then they just fall right into our trauma system, our trauma alert. But I don't really know how the actual facility decides where that patient goes or where they go by ground or air. That would be up, I guess, to the correctional facility.
Thank you. Representative Seabaugh.
Thank you. I know there's some pilot programs going on. I know Grady's doing one carrying blood products now, and it sounds like there's some more throughout the state. And I know that that's making a difference in some severe calls involving hemorrhaging. Do you see that as something moving forward for all of EMS to start carrying blood products?
So, yes, that is hot right now, and you can see if you can start blood early at the scene, and not in everybody, but in the right patient, and with you being a Grady EMS paramedic, you pretty much know what those patients, who that would be, based on your experience. If we can get blood out there, then we can get started earlier. Now, there are some issues with paramedics and scope of work and things that we need to work through, but some other regions in Georgia have already tackled that problem and started working through it. Emily, you all are really working through that as well. So it's very doable. So if, as legislators, as you hear things moving your way or you see things, that's something that certainly the commission supports and the trauma community supports, to let our paramedics start blood in the field. It can be life-saving.
Yeah, thank you.
Okay, that's the end of the question, so before we say the final thank you, there are three other gentlemen that look like they work in the paramedic field, or could you stand up and each one tell us who you are and where you work, and are you just here as support, or are you from another area? Don't be shy.
So I'm Terry Cobb. I'm the EMS director from Lawrence County, Dublin, Georgia. Me and Chris have been friends for a long time, so I was communicating with Emily and them in the morning of Chris's wreck. I'm also a member of Georgia Trauma Commission just last year. So.
My name's Todd Daniel. I'm the Assistant Chief of Operations for the 911 Division at South Georgia Medical Center EMS.
Okay.
I'm Jack Paulson. I'm the Assistant Chief of Special Care Transport for South Georgia Medical Center EMS.
Well, thank you all very much for what you do and for coming up and being such great support for the commission and this wonderful gentleman who has had such a life-threatening accident and has pulled through very well. And, other than being a little soft-spoken, I think it looks like you're doing great. A lot of good wife care, I bet, also, and home, besides that from the community. So thank you. And Dr. Ashley, thank you very much. Like I say, I don't want anybody to get hurt, but the story really hit it home. So when you come back again, if there's another such success story, we'll try to get all our friends here and make sure you have a full house to hear, what the Trauma Commission has meant to us, and let us see. Sometimes you're right. We don't know how we help people or ever see how the money was spent, and I can tell you it's been well spent with you. You started out on a shoestring. It's still not a whole lot, and I personally really appreciate it, and I know all my members do. So thank you very much again for coming. Thank you for the work you do at the hospital, and to all of you that work to save patients across this state of Georgia. Thank you very much. And with that, we are adjourned.
Thank you, Madam